Thank you all for being here. I'm very excited to share with you the work that we've been doing at the University of Virginia Health System, and we're also just started doing it at the Children's National Medical Center in DC, so not too far away from here, and in other health systems as well across the nation. So I want to draw a line. I'm not going to talk about artificial pancreas today, but I would love to share with you what I think the bottom line is, which is how do we measure the ROI? And when I talk about measuring, it's not an estimate, it's the actual value of what the ROI is, giving your data in your health system. So I want to also draw a line. It's a contrast line between Dr. Gibbons' presentation this morning. It was nice it was a nice presentation for dreamers about innovation and technology. But unfortunately here I'm going to share what is the reality in the grounds, what's there, what are the challenges and roadblocks that you probably are most likely to find in your institution as well. So, some of you might know Dr. Soon Shong. He's a brilliant entrepreneur. He's a medical doctor, surgeon by training. He performed the first pancreas transplant ever. And he founded two very successful companies, biotech companies in diabetes and cancer. He's now leading the Moonshot project, and he's for cancer and precision medicine. And he's working on all these shiny innovations. And when he was asked just a couple of weeks ago, what is going to disrupt healthcare? He said, the only thing that's going to change healthcare today or in the future is if we can measure in real time the outcomes and the cost. So the opportunity today for us here in the room is that I think even though telemedicine started 20 years ago, maybe even more in some institutions, I think it's still in its infancy when it comes to a business model for telemedicine, clinical standards for telemedicine, and so on. So I have a trophy here, but I want it to be a holy grail about how do we measure this notion of ROI and return on investment. And it's not your typical financial return on investment measure, because it incorporates not only the cost of doing telemedicine, but also not only the revenue, but it also incorporates the quality of care outcomes. How well is it doing for your patients? How well is it doing for your patient population, your health system, the healthcare system in general, the payers, and everybody else? So, however, when I went online, this is when I was starting up, I went online and I Googled ROI for telemedicine. It was a problem of finding a needle in a haystack. The problem is that this notion of ROI for telemedicine, it's either an estimate, so people would say we're seeing 100 patients per day, $10 per patient, that's $1,000 revenue. That's not what we're talking about here. The second, it's always tied with clinical outcomes. And what I mean by that is that usually we hear this argument about, for example, we're having a shiny device or we're starting a remote patient monitoring program, and we say we're going to reduce the length of stay by 0.6 days. For your institution, the cumulative saving is $2 million, right? So it's a big claim, but they're saying that's the cost savings, but it's estimate and it's tied to clinical outcomes. What we're doing here is not this, but actually dive deep, collect the data, and see what it is actually that we're getting in terms of revenue, what is the actual cost, and what is it doing for the patients. So I'm going to showcase the UVA situation here, and it's actually working with a few other health systems. the problems and challenges and roadblocks are consistent across the board. Our approach is very simple. You need a central governance model. We cannot do this if within the institution there is no cross-organizational unit or a department or a center for telehealth or an office of telemedicine where everything is together there. You just cannot go with one-off projects and try to measure the ROI for telemedicine across these different specialties and service lines. The second, no surprise, you need to include the health systems leadership, and you will know why. It's because we're asking for clinical data, we're asking for financial data, and this data is very sensitive. And a lot of groups are, and resources within the institution are involved in the process. The process is easy. We collect the data, we analyze the data offline, but we do not stop at that one simple or one-time analysis. We continue to automate the process of collecting the data, analyzing the data, and showing you or giving you on your fingertips the real-time dashboard with reporting tools so you can look at those metrics that we define together with the administrative team and the clinical team. However, the reality of things is not so bright. 80% of the world's data is unstructured. And I actually would argue that with healthcare, it's a lot worse. Number two, the data is coming from so many different places. And usually this data is in silos. And that's because of many reasons that we all know. Three, the data is very inconsistent. The example for this would be in so many different departments or in so many different units, sometimes the same procedure is called two different names, or the same department or location within the same hospital in two different systems that are reflecting what the hospital is doing are different. The fourth, the data is complex and diverse, and I think nobody needs an explanation for that. So we defined these 5 what we call golden rules. Do not be afraid of what we call, I hate using buzzwords, but big data. When I say big data, I mean big data, not like the buzzword. So basically we collect the same data from different teams, from different systems, again and again and again. And that's how we determine how reliable that data is. Because when you do it again, all over and all over from so many different sources, then you determine what is actually that core data. The second rule is that you need to dive deep into the data, and by that I mean go to the individual clinical record, go to the individual charge for that procedure, go to the individual payment for that procedure. Rule number 3 is that you need to involve your medical champion, because you need so many resources, and if you try to do it on your own, I don't think you will achieve your goal. The rule number 4, I mentioned this morning that the data is very rich, right? I think we got rid of most of the papers around in a hospital, so we have all the data digitized, but it sits in systems that are unstructured. So the data is actually rich, all the information is there, but how do you extract the knowledge? How do you turn it into actionable information so you can monitor how well you're doing, you report to the supervisor, and you do something. You take an action to correct what's wrong and keep moving forward and improve the program. So this is what we built at the University of Virginia. It's a program called Telehealth Resource Program, or just TRP. It's an information system for the Center for Telehealth or Office of Telemedicine, where we collect the data automatically. we combine clinical, operational, financial data and give you a real-time dashboard so you can articulate how well you're doing on a regular basis, but also improve that performance. The way we do it is we work with multiple data sources. We connect with the EMR to get the clinical records. We connect with the telehealth technologies to get the call logs from the back end of the video conferencing system, so we know what time the doctor made the call or received the call, how long was it, how many disconnections, what's the packet loss, what's the jitter, and monitor the whole process. We also need access to the financial system so we can monitor how much reimbursement are we getting. And also, I'm going to talk about a notion of downstream revenue for all these service lines. I mentioned that we define key performance indicators and metrics. They're clinical, they're operational, and they're financial. The one thing I want to mention here is that this system is not just about clinical data from the EMR. It's not just about the financial data. It's also about the operational data. It's about the contracts that you have with your sites. It's about the equipment inventory, so you know where the equipment sits, how much it's costing you, when it's going to need maintenance, and warranty and everything. And we can also keep track of the different virtual video conferencing spaces. This is what it looks like. It's basically a very simple dashboard. We love using simple graphics. This shows the different utilization, and we can utilization data in terms of clinical volume and clinical encounters. We can show the trend lines. We can show the distribution of these encounters based on their location, based on their diagnosis codes, based on providers, and the use cases are endless. These are the different graphics where you can compare per year or per program or per provider or per department. And these graphics are available to you to download or to include it in what we call an automated report generation tool, where you get access to all that data on a click of a button. Basically, it downloads all these graphics into a PowerPoint or PDF or just images and a JPEG and PNG. So the last piece is what we call telehealth coverage map, because we have all the information about where everything is happening. We can go and show you the different locations, and we have all sorts of information about these partner sites, and we can show a lot of information. We can also import new patients and link them with those facilities, so we can send information to the referring physician or the patients themselves. Okay, so I talked about how are we going to measure this ROI and what are the outcomes that we're looking at. So I'm going to show the specific case of Telestroke. We're doing this for a lot of service lines, but we chose Telestroke because it's the one where we feel more comfortable about, about the data and where it's coming from. Basically, we analyzed the revenue. And in terms of revenue, we have contract revenue from the different sites. We also have direct revenue from reimbursements. And we define the notion of downstream revenues. And the way we define downstream revenue is by including all subsequent inpatient, outpatient visits for those telestroke encounters. And we defined algorithms, so based on the individual encounters, based on the admitting diagnosis codes and primary diagnosis codes, we exclude the ones that are not linked to that specific telestroke encounter. So based on this analysis, we can now monitor in real time how much revenue the hospital is getting, how much revenue the telemedicine office is getting, and also in terms of downstream revenue, I want to draw your attention to the fact that when a patient comes to the hospital, they get two bills, one professional and one for the facility fee. We're monitoring both of these. This is what the clinical outcome dashboard looks like for Telestroke. We monitor all these efficiency times or efficiency metrics, that's what we call them. And basically it measures the door-to-needle time and the different response time from both the telemedicine technician and the clinical team as well. We also are able to link all this clinical data to, as I mentioned before, to the video conferencing backend. So we measure the different quality metrics in terms of how many disconnections happens during the calls, and the jitter and packet loss, and so on. And I wish I could scroll down, but it's actually a fixed image. But in the next half of that screen is actually the measures of TPA administered, the measures of transfer rates. We also show the different distribution across the per diagnosis code, basically, the TPA administered by diagnosis code. So in the future, the ultimate goal is that we want to define the gold standard of what kind of quality of care we're talking about. What should we monitor for the different service lines for telemedicine? The second is that we need to make sure that it's self-sustainable. So one thing that's not on this slide is that grant money is not on this slide. And I think we would all agree that for telemedicine, grant money is a big thing. The bad news is that if not managed properly, grant might hurt the sustainability of the program. Imagine in 5 years, if the money is not there, do you know if you can survive without additional capital from somewhere? So those are really the questions that interest me. So that's the sustainability, the self-sustainability of the program is based on this notion of ROI-driven business model. The third one is to make sure that these programs are scalable, which means you can take more patients in, you can explore more or include more geographic location. That's by streamlining and standardizing the different processes for care delivery in telemedicine. Okay, so these are the last two slides, and the first vision that I have here is why can't we, for the healthcare space, create something like what Bloomberg created for the financial industry? It's still sensitive data. It was really complex, but they were able to solve the problem. So I would love to solve that problem alongside health systems, where I think most of the opportunity is. It was mentioned today that these direct-to-consumer companies on the side and insurance companies, private insurance companies, they know exactly what they're talking about. On the other side, I'm seeing health systems trying to catch up on that lag. And I think most of the opportunity is in the health system side. And that's why we're seeing all these private companies now trying to make some partnerships with health systems. So for the ROI engine that we're working on today, basically, if you're a health system and you want to invest in a service line, you want to know if that's worth the investment or not. And we are developing a tool where basically based on your own data and based on available parameters like your geographic location, the size of your investment, your traditional service lines that you have, the characteristics of the population, your own patients, whether it's worth investing and implementing on your own or actually not do that and be a little bit more conservative and look for partnerships with either the private sector or your peer health systems. The second vision I have is, why can't we create a telehealth marketplace for health systems? Now imagine in a perfect world, we don't have these issues of credentialing and licensing and the months-long process for defining contracts between two health systems. It shouldn't be that difficult. But if you imagine a world where these things are solved, why can't health systems go somewhere and shop for coverage for 10 telestroke patients per month? And it would be as easy as go out, look for something. It would be like Google, look for a profile of a health system, see if they have the capacity, and you click, you pay there, and boom, it's taken care of. And it's still your, they're still your patients, and it's easy, it doesn't take months. I think this would help a lot the scalability and the sustainability of telemedicine in general. So with that, I would like to thank Dr. Ruban, Dr. Solinsky, David, who is the director of program of the telemedicine office at UVA, Lara, who is here. I hope I solved some of your problems. And in general, the UVA Office of Telemedicine and Center for Telehealth team for believing in what can be done. And I hope other health systems will kind of follow this path. But I don't care about following this path with me or not. It's just I think I believe in the cause, and I hope we solve this issue of cost and revenue and how well it's doing for our patients, and not an estimate, but an actual measure of that. So thank you for your attention.
Thank you.